So as we discuss all the criterias, all the probing depths, the various depths which apply to each stage, what are the grading criterias? Once we discuss all of those, it will give you the capacity to answer the questions in the exam with various histories. So suppose you're given a certain amount of probing depth, a certain amount of bone levels, age of the patient would be provided to you. Then the complexity factors are also given in the history. So as you have seen the questions, as we were doing in the advanced file also in the last class, so you have seen how the age of the patient, the level of the bones, the probing depths, and then the complexity factors, the patient's medical history related to the diabetes and smoking, everything else is provided to you in the exam. Is that correct? So the entire pieces of the puzzles are in front of you in the exam. Point is, today we will learn how to put those pieces together, how to make sure that we understand the age, the amount of bone loss, the probing depths, the total attachment loss, the complexity factors, vacations, drifting, etc., and the medical history combined together, and we successfully land the staging and the grading. That's what we want to learn today. We also learned in yesterday's advanced file class, we learned about the BPE scoring. We learned about what each score means, what history provided, and the presence of calculus, the black band visible or not, signifies the BPE score. Based on the BPE score, you learn to assess the treatment plan, further treatment plan of the patient. Is that correct? So everyone understands the BPE part, right? That's your basic periodontal examination. Now, staging and grading is your advanced assessment when periodontitis is already established, when your BPE scores would be in the 3 and 4 and the asterisks, and when you do the full perio charting, then you can assess the staging and the grading also. So you know it's all interrelated. When a patient comes to you with a periodontal problem, that's how it starts, with the plaque and gingivitis assessment, knowing the BPE scores. When the scores are higher, then it's an established periodontitis. You go for full perio charting. When the full perio charting details and the OPG and the radiographic findings are seen, then you assess the stage, and based on the medical history, you would assess the progression speed of the disease. That will give you the grade. So mentally, do you have a picture that even in the exam, how a patient can be falling into the category of periodontal diseases, which includes gingivitis and periodontitis and your peri-implantitis as well in case of implant patients, right? So the understanding of all the three very core concepts would give you a huge edge in the exam. Understood how crucial this is to mark all the perio questions? Somewhere or the other, these three very core concepts will form the base of the questions which come from the perio discipline in all your sections. Does that make sense? And then it would be incorporated with the prosthodontic challenges, because the rehabilitation would be asked, the prosthesis would be provided, the after periotherapy. So then it becomes a multidisciplinary situation. So as in the advanced file classes, we did the BPE assessment, the BPE classification. We learned about each score. We learned about what should be the treatment plan with each score. Everyone remembers where the perio charting starts, where you don't do the full perio charting, and then what is recorded in what sequence when you're doing the perio charting. Crystal clear for everyone from the last advanced file class, right? Wonderful. Now, we also did one question from the exams where we did the staging and the grading, right? Now, we learned about, we saw one history. Today, we are going to in-depth dissect what are the factors, so that we have a mental picture, so that with variations, we are able to immediately select the stage and grade. That's what we are intending to do in today's class. So let's start with it. So as we know, there are 4 stages and there are 3 grades. stage 1 to 4. So 4 staging, and A to C, that means 3 grades of progression. So staging 1 to 4 of periodontitis is defined based on severity. The stage is how much damage has happened. What is the breakdown that has occurred? What is the attachment loss that has occurred? How severe is the periodontitis? It is an established one, we all know that, but how severe it is. And complexity of the management, how complex would be to treat it. Complexity means that how complex would be the therapeutics of it, right? The treatment phase of it. So severity would be assessed by the attachment loss, by your bone loss, and the number of teeth lost due to periodontitis. Does that make sense? Everyone agrees with that, right? That's your severity factors: attachment loss, bone loss, and teeth loss because of periodontitis. Complexity factors which would affect how complex the treatment can get is how deep is the pocket, and are there any infrabony defects, vertical bone loss, then furcation involvement, and tooth hypermobility, masticatory dysfunction. It includes the ridge defects as well, also the drifting, the migration, pathological migration of the teeth. And then you also have the component of extent. All the stages can be localized or generalized depending upon the number of teeth involved. Less than 30% is localized, more than 30% is generalized, as was with the old classification as well. The localized and generalized extent is based on the number of teeth involved. So all these 4 stages are still bound with the localized and generalized component. Now, the grade of periodontitis is estimated by the direct or indirect evidence of progression rate. So it can be slow, moderate, and rapid progression, right? And when you are assessing the patient and see the severity, then you also need to know how rapidly or slowly or moderately it is progressing, right? So these are our 2 main important goals when we are assessing the patient, when we are checking the histories provided in the exam. And that would not just give you the answer to one question, which is the apply the stage and the grade, but it will also give you the answer for the challenges while you may face while doing the treatment for the patient. Is that correct? So the objectives of periodontitis case definition system. Why do we need this system? Why the staging and grading system is even asked in exam? Because as I said, that this will not just answer one question, one of the question in those SPQs, which would be the direct question, staging and grading. Then the question gets asked after management, how the stages and grades change. We need to learn about that as well. You get questions around that premises also. Then the other premises would be the management part, knowing the questionable, hopeless, fair prognostic, all these situations, right? Where you know that the treatment is so complex that it might have to just go for extraction, it's a hopeless prognosis, or it's a questionable prognosis, or it's questionable to hopeless prognosis, or it is a fair prognosis, right? So it will also give you the prognosis of the particular tooth or teeth in question. Then it would directly affect your treatment planning. So this staging and grading concept alone is giving you the information gathering data questions. Then you're also learning and establishing a diagnosis. So it's also helping you answer the questions on diagnosis and clinical management cluster. And then when you plan the treatment, it also gives you the treatment planning cluster. Is that correct? And to prevent the progression rate, once you know the progressive factors, it will also help you. What will it help you? The health promotion and professionalism cluster. Is that correct? So that's what it is equipping you with. All this single concept is preparing you for all the 4 clusters or not in the perio section or in the perio discipline questions. So that's huge power in your hands with this learning, right? So now the case definition system should facilitate the identification, treatment, prevention of periodontitis in individual patients. It totally sums up the first sentence. See this? Identification. How do you identify with the information gathering cluster? Treatment. How would you decide treatment with the diagnosis cluster? Then you decide the treatment plan, and for the prevention, you apply the health promotion professionalism. Absolutely summed up, right? So you know that this article and classification alone equips you for all the 4 clusters of perio questions in exam. So given the current knowledge, a periodontitis case definition system should include the 3 components, which is identification. We have done the BPE scoring. Now today we learn the total assessment of the various factors which will put your patient in either stage 1, 2, 3, and 4. I immediately define what criteria puts you in 1, 2, 3, or 4 stage, and what findings given in the patient's history will put the grade in A, B, or C. At the end of this article, at the end of this lecture today, you will have full knowledge to look at any history and identify those, right? So you'll identify the patient as a periodontitis case, identify the specific form of periodontitis, and then the description of the clinical presentation and the other elements that will affect the clinical management, prognosis, and potentially broader influences on both oral and systemic health. Because periodontitis is not just affected by the systemic situation. It also, vice versa, affects the systemic situation. Is that correct? We have done that in 2 situations. In diabetes, diabetes does not alone affect periodontitis. The glycemic control, vice versa, affects diabetes as well, periodontitis, and the glycemic control, vice versa, affects the diabetes, periodontitis as well. So there is a interrelated situation. Excessive glycemic control, more destruction. More periodontitis, poor diabetic control. So they both lead to each other, right? And then similarly in pregnancy, pregnancy makes patients more prone to have periodontitis. And periodontitis in pregnancy leads to more complications in pregnancy. Does that make sense? They are both a feedback loop. They're working vice versa. So as a professionalism cluster or health promotion cluster, or as a practitioner, is it not important to understand knowing the systemic history of the patient and how it affects the periodontitis, but also controlling their periodontitis to improve their medical health, the systemic health, right? So this knowledge will also equip you with those questions where the question gets asked how the controlling periodontitis will affect your patient. Like we also have a similar question when HbA1c is given, the effect on periodontitis is asked. But we have done in the Mega Master file a lot of questions for practice, how controlling the blood sugars, the periodontitis, and providing the SRP, the scaling and the root planing, can improve the glycemic control of the diabetic patients. Yes, everyone remembers here? We've done those questions in the Mega Master file also, right? So when you've practiced all those questions and the concepts, in the exam with whatever variations, you are able to confidently answer those options. Now, a patient is a periodontitis case in the context of clinical care. So how would you define your periodontitis? First of all, the attachment loss should be detectable at more than or at least 2 non-adjacent teeth, right? So a single tooth affected with attachment loss is a localized problem on that tooth, is not the periodontitis. It would not be categorized as periodontitis, right? Then the buccal or the oral attachment loss should be 3 or more millimeters, and pocketing of more than 3 millimeters should be detectable at least 2 or more teeth which are non-adjacent, right? So attachment loss 3 minimum, pocket depth 3 minimum. That's when also your BPE score, the band goes fully in. That's what the attachment loss is, and that is where you categorize it as your established periodontitis. And that's when you do the full perio charting. Is that correct? So perfect. That's why when we did the BPE scoring based on the findings, we established the periodontitis. And then if we are given the scores, we did a question where the BPE scores were 3 and 4 and asterisks. And we performed the full assessment of the periodontal assessment and charting for them, right? Now, you will observe that the clinical attachment loss cannot be ascribed to non-periodontal cases. So you have to make sure that the attachment loss is not because of non-periodontal conditions. Like it should not be of the traumatic origin, gingival recession, like we did in the localized Tillman cleft situation, right? Then the dental caries which are extending to the cervical area, and that had led to the inflammation and violation and the attachment loss. Presence of the attachment loss on the distal aspect of second molar, which is associated with malposition of or the extraction of a third molar. That will also not be your periodontitis situation. It should also not be an endodontic lesion, which is draining through the marginal periodontium. So an primary endo secondary perio situation also it should not be. Like a draining sinus would not be categorized as that. Or a deep narrow probing defect is also seen in VRF, right? We did a question yesterday also, a mid-buccal 8 mm pocket. Everyone remembers that? So that is also a VRF situated related, your loss of attachment will not be counted as periodontitis. So you need to segregate those things from the history. That is why when we did the question and we had a your mid-buccal narrow pocket defect, 8 mm attachment loss, we categorized it as for your vertical root fracture. We did not categorize it as your localized periodontitis or periodontitis per se, right? So the other periodontitis, the classification is, it's either necrotizing periodontitis, which is your progression of enug to the periodontal tissues. Other reason of periodontitis is a direct manifestation of systemic diseases, like your Papillon-Levifer disease, like your leukocyte adhesion defect conditions. Even in Down syndrome, we have as a direct manifestation of systemic disease, cyclic neutropenia, right? We have done all those concepts in our core classes. Yes or no? Everyone knows that. I've covered all of these in the core classes also. So anything on those systemic situations come in the exam, you would be able to confidently answer those. Then comes your true periodontitis, which is pathogenic, microbial, coming from your anaerobic bacteria or mixed bacteria. Then necrotizing periodontitis is characterized by history of pain, ulceration in the gingival margin and the papilla. It starts with the gingival papilla, right? The anug. And then it progresses to the involvement of the PDL and the bone. And it mostly is seen in the immune compromised patients. Anug would be seen in highly stressed situations or like lower socioeconomic situations, right? And then it progresses to NUP, which is your necrotizing periodontitis in immune compromised situations in the cases where the NUG originates. Now let's see how the staging and the grading are classified. The primary goals in staging and grading a patient with periodontitis. So goals are to identify the severity and the extent. What is the attachment loss? How much the bone has been compromised? How many teeth the patient has lost due to this periodontitis situation, right? And what are the effects seen in the mouth already, which can make my management complicated? So knowing the severity and extent and assess the complexity, knowing these two situations are important from the stage. Once I tell you stage 3, immediately the attachment loss, the bone loss, and your complexity factors should come in your mind at the end of this article, right? That's the goal or not? I say stage 4, immediately attachment loss, the level of bones, and the number of teeth lost already in the patient's mouth. What would be the complex factors? How the mouth and jaw would look like? You would be able to imagine that, right? And then the grade also, even if I mention the grade, you would know, okay, what systemic factors might be present that's making the patient's grade like that. So the moment somebody says stage 4, grade C, or stage 3, grade B, immediately the dental situation should start visualizing in your head. That's what the goal of this article is, right? So classify the severity and extent and assess the complexity. That's our primary goals from the staging. And from the grading, we need to know, if once I say it's grade B, you know it's moderately spreading. Okay, so I know what is the future risk, how immediately I have to start the procedure, or if the patient is not cooperating, how can I educate them and encourage them to improve their periodontal health, right? And then if I say it's grade C, you would immediately know grade C either comes from excessive smoking or it comes from uncontrolled diabetes. So I need to educate my patient how to improve those factors to help their periodontitis. And I need to provide them the therapy to improve their systemic disease. It all, as a clinician, should start making sense to us. Is that correct or not? So these are the primary goals when we learn this specific classification. And it helps us answer those questions meticulously in the exam. That's our primary goal as well here, right? So the staging would be stage 1, 2, 3, and 4, which is stage 1 is initial periodontitis, and stage 2 is moderate periodontitis. Stage 3 is the severe one with potential for additional tooth loss. And stage 4 is advanced periodontitis with already extensive tooth loss and potential for the loss of dentition as well. So in progression, stage 1 is initial, stage 2 is moderate, 3 is severe but potential for more teeth loss, and 4 is advanced, already the teeth have been lost, and there can be a loss and danger to the entire dentition as well if not controlled. And then how rapidly it's progressing is your grade A, B, and C. So far, so good. Everyone's with me, hooked on, and curious to know how we now classify. So stage 1 periodontitis is borderland between your gingivitis and periodontitis. It is the early stage when the attachment loss has begun after the established advanced gingivitis, right? As such, the patients with stage 1 periodontitis have developed the periodontitis in response to persistent gingival inflammation and the established biofilm dysbiosis. Dysbiosis means the plaque has now become pathogenic. Anaerobic bacteria is present prominently there and is leading to the depletion and attacking your PDL apparatus, right? Now, if they show a degree of clinical attachment loss at a relatively early age, these patients may have heightened susceptibility to disease onset. So, we'll also learn a factor of percentage bone loss by age. I'm going to teach you that, and you would have that information handy in the exam as per the history. Age is always provided. The level of the bones you either is provided in words or provided as your OPGs. But we can derive that, whether it's your coronal third which is lost, or up to the middle third, or up to the more than middle third involved going towards the apical third of the root. We can all visualize that OPG and make that, right? So for that matter, for our internal class, soon as I promised, I'm bringing you the radiographic assessment class also. So that would be the part of the private class, but also that would be part of the crash course also. So we'll start that once the crash course begins so that all the students can take that together. But that would be an internal, our private class along with your advanced file classes, right? So, and I might create a mock and just a quiz for your practices as well during this batch only. So basically to practice more, to see on the radiographs the bone loss, the attachment loss, that will give you the percentage bone loss, and age you already have handy. So imagine if you know 25% bone loss, 30% bone loss, 50% bone loss, or 60% bone loss divided by the patient's age, and what factor comes out and puts them in what category. So we are going to learn that as well. So it is recognized that early diagnosis may be a formidable challenge in general dental practice. Periodontal probing to estimate early clinical attachment loss, the current gold standard for defining periodontitis, may be inaccurate. So that's why the salivary biomarkers or imaging technologies can increase the early detection of stage 1 and can prevent its progression. Best is to identify the patients in stage 1 and arrest their progression, provide them the treatment as needed, educate them, motivate them, and arrest most of your disease and control it at that stage only. Stage 2 is an established periodontitis in which a carefully performed clinical perio examination identifies what damage has already occurred on the tooth support. Careful evaluation of stage 2 and patient's response to the treatment is essential, and the case grade plus treatment response can guide more intensive management for specific patients. You will start with the initial treatment, non-invasive treatments when needed, and then see what are their response to the modalities. Are they responding to the oral hygiene? What is their maintenance situation looks like, whether they need complex treatment or not. So stage 2 also is like savable situation. With the initial therapy and the patient education and motivation, it can be controlled. Now, stage 3, it has already produced significant damage. When you assess and classify a presenting patient in your practice who's at stage 3, you know that the damage already has taken place, right? The absence of advanced treatment and the tooth loss has also occurred, right? Or if you don't provide a complex treatment immediately, which would include the maybe GTR, regeneration, right? And furcation treatment. If you do not provide complex treatments now, the tooth loss can continue to happen. So stage 3 should immediately ring those bells that the complex treatment is needed, right? Stage 1 and 2 patients, you know that you can start with SRP and then see the patient's response. So even with the classification of stage 1 and 2, now the diagnosis is helping you with the treatment plan? Yes or no? Are we achieving this goal now mentally? These paragraphs that I'm reading, I could simply jump to the table and give you the factors and be done with it. But I'm giving you the tool and equipment to actually solve all the 4 and 5 questions that come in all the clusters, right? Is that correct or not? So as you see the stage 1 and 2, you know that, yes, I can do the initial periodontal phase. But as you see the patients in stage 3 and 4, you would know that a complex treatment would be immediately needed. And plus, you would know what are the hopeless teeth, what are the questionable teeth with your stage 3 and stage 4, right? So you know what is going for extraction, where you can perform the treatment and wait for the outcome, right? All those things. So the stage is characterized by the presence of deep periodontal lesions. The attachment loss is greater than the stage 2, and the pocket depths are also deeper. And there is vertical bone loss, deep intrabony defects, which are your vertical bone loss, right? Furcation involvement is established. And there is history of periodontal tooth loss due to periodontitis, not other causes. And presence of localized ridge defects that can complicate implant tooth replacement. That means that while the tooth got extracted, already the buccal bone and lingual bone, the cortical bone was complicated and lost. So the ridge defect has already established, right? So if you plan implant, you might have to go for the grafts first. So there are already ridge defects established due to those lost teeth. Does that make sense? Full sense? Now, in spite of the possibility of tooth loss, masticatory function is still preserved in stage 3. So masticatory loss and your drift, pathological shift, right? Drifting of the teeth are 2 establishing factors for stage 4 and the number of teeth which are involved. So all these factors, the furcation, the vertical defect, loss of teeth, ridge defects, they would be present in stage 4. Then the stage defining criteria comes from the masticatory function lost and the drifting and pathological shifting of the teeth, flaring and drifting. So these are the two stage defining terms. If you find in the history, you know what to mark them. Stage defining terms would be called that, right? So are we going to miss that golden keyword ever in the history? The drifting, the flaring, or the masticatory function loss? These are your golden keywords immediately helping you in the history to identify. And if you see the golden keywords in the exam, do not miss a single one of them. You can immediately connect the dots with the concept and all your answers and questions would be attempted correctly. That's the major way of success, how you identify the most important golden keywords in provided history. And every question has that. And that's what we are training when we practice the Mega Master and Advanced File. That's what we are training for, to train our eyes to look at the golden keywords with each presented question. Are we doing that or not? So then let's look at stage 4 periodontitis. And as I said, it is already a lot of damage to the periodontal support. Attachment loss is greater. There is significant tooth loss due to periodontitis, and which has now translated to the loss of masticatory function, a golden keyword which is stage defining. In the absence of proper control of periodontitis and adequate rehabilitation, the dentition is at risk of being lost. The stage is characterized by the presence of deep periodontal lesions that extend to the apical portion of the root and or history of multiple tooth loss. It is frequently complicated by tooth hypermobility due to secondary trauma and the sequelae of tooth loss. There is bite collapse and drifting. Again, stage defining criteria. And frequently, the case management will require the stabilization and the restoration of masticatory function as well. And the grade is irrespective of the stage. The periodontitis may progress with different rates in individuals and may respond less predictably to treatment in some patients and may or may not influence general health or systemic disease. So that's why even stage 1 and stage 2 will require more of your attention if it is grade C. Does that make sense? If it's a stage 1 and 2 patient and you know you have to go conservatively and the initial phase and the complex treatment is not required and a lot of damage has not yet occurred, but it's grade C. So that again is a red flag, and then you should start looking at it. Okay, the patient education would take a different route, right? The management would take a different route. The urgency of providing the treatment would take a different approach. Does that make full sense? So far, so good? The recognized risk factors such as cigarette smoking or metabolic control of diabetes affect the rate of progression of periodontitis. Consequently, it may increase the conversion from one stage to the next, right? Is that true? So smoking and diabetes are the predominant effects. There are some emerging risk factors also, which is obesity, then specific genetic factors, physical activity, nutrition, but they are not yet part of the classification because there probably is more evidence that's required for them to immediately be the part of the established risk factor. Right now, it's smoking and your diabetes, which are the established grade defining risk factors. Now, this is the table that we need to understand. Once you take this lecture today, you finish that, you will not need to refer back to this table. I assure you that. That's how crystal clear the classification will be in your head. You would not require to go back to this table to even classify a case, right? So that's our goal, and let's see how we can do that. So it is your interdental attachment loss. So we know that stage 1 is initial attachment loss. So it's 1 to 2 mm. It has been started, but it is not an established periodontitis. It can be reversed at this stage. because we know that at least 3 mm attachment loss is mandate, right? But in this, 1 to 2 mm is the attachment loss. Stage 2 is 3 to 4 mm, so established one. Stage 3 is the moderate one, so more than or at least 5 mm has established in stage 3 and 4. Severe and advanced, right? Severe with complex factors, severe with complexity factors, plus mastication involved, plus number of teeth loss is already more, and plus your drifting and flaring. Does that make sense? Radiographic bone loss is less than 15%. Only coronal third of the bone will be involved. And in this stage 2, established, still 15% to 33% bone loss, but still in the coronal third. Stage 3 is, so if on OPGs you start looking any bone levels going to the middle of the root, you immediately know stage 3 or 4, right? Going to the middle or the apical. So if OPG is given and my bone levels are middle, and attachment loss is not given to me, probing depths are not given to me, but middle, and then I see driftings, tilts, loss of teeth more than 5, I know it's stage 4. But I see tooth loss is less than 4, no drifting, but middle, but all teeth are straightly aligned, stage 3. Does that make sense? So I can just look at an OPG without a lot of information given to me. I can still tell, right? Stage 3 and 4, immediately the drifting and flaring will tell me on the OPG, right? The bone levels have to be on the middle or beyond. Teeth loss 4 or 5 more, but if bone loss is already there and drifting flaring is already there, even if tooth loss criteria is not met, one of the criteria being met there still puts our patient in stage 4 or 3. Is that correct? So tooth loss in 1 and 2, in the early and the established one, moderate, in like the mild and the moderate one, there is no tooth loss due to periodontitis yet. That's why, because there is no tooth loss yet, these patients can be handled with your non-invasive periodontal treatment. 3 and 4, the patient comes to you, he has already lost few teeth due to periodontitis. And it would be less than 4 or up to 4 in stage 3 or 5 or more in stage 4. Simple. So attachment loss 1 to 2, 3 to 4, then 5 and 5. And number of teeth loss, nothing in 1 and 2, and 3 and 4 is either 4 or 5 and above. Does that make sense? And the bone levels, coronal, stage 1 and 2. Middle apical, stage 3 and 4. Drifting and flaring, stage 4. Simple? Is this simplifying or not in your head? Now let's look at the complexity factors, which helps us immediately define the stage. So stage 1 and 2 definitely have less than 4 mm or 5 mm probing depths. The bone loss is mostly horizontal, the periodontitis. But in 3 and 4, the complexity factors start. Probing depths are higher, 6 or more, right? Attachment loss is 5 and more. Probing depth is 6 or more. Vertical bone loss is established. Furcation is established. Moderate ridge defect is also seen. Stage 4 is all of this and masticatory dysfunction. And because the teeth have been disrupted, they cannot chew properly. And secondary occlusal trauma is coming now, right? It's not the primary occlusal trauma. This secondary occlusal trauma is coming from the periodontitis, result of the periodontitis, right? Due to mobile teeth, right? Then severe ridge defect and the defining factor masticatory dysfunction and bite collapse, drifting, flaring. Agreed? And more than 5 number of teeth loss. So anywhere you see 5 or more teeth loss due to periodontitis or masticatory dysfunction or drifting or flaring and severe ridge defect, you would be immediately be able to classify and put it into stage 4. Yes or no? Now, very, very important concept. This gets asked in exam as well, that the stage was defined and you did the treatment. What would be the stage now? and you feel that they tell you that the furcation defect is probably repaired, or it's responding well, it has healed, there is no established pathological situation in the mouth, does the stage change? Does the grade change? So let's talk about the stage first. Initial stage should be determined using clinical attachment loss. That's what we are doing. If not available, then the bone loss is observed. In ideal situations, you should do both, right? But the initial investigation, if the information gathering cluster question asks you what would you do first, then the attachment loss is established first with the probing depths. Is that correct? That's what we also learned in the full periodontal charting in the yesterday's class. Perfect. If not available, then the RBL should be used, the radiographic bone loss should be used. Then information of tooth loss that can be attributed primarily to periodontitis, it can modify the stage definition, right? If you have the information on tooth loss, suppose there are lesser probing depths now, but there are 4 teeth already lost to the disease. Would that be a stage defining factor or not? It is, right? That's why any one factor which comes from stage 3 and 4, even with lower probing depths or lower attachment loss, can become the complexity factor and stage defining factor. So complexity factors may shift to the stage to a higher level with the furcation involved, 2 and 3, and then immediately you go to stage 3 or 4 depending upon other findings of drift and mastication and the number of teeth loss. Even at lower attachment loss, you can have the shift stage defining factors, moving the stage from 1 to 2 to maybe 3 or 4. The distinction between 3 and 4 is based primarily on complexity factors only, because both would have greater attachment loss, right? Teeth loss would be 4 or less in stage 3, 5 or more in stage 4. Then masticatory and the drift and the flaring. Does that make sense? Are those golden keywords in your head now? You're never going to forget these keywords now when you see in the exam. I can assure you that. And in the center, you're going to immediately, they will all come out to you, zoom out to you, right? So it should be emphasized that the case definitions and our guidelines that should be applied using the sound clinical judgment to arrive at the most appropriate clinical diagnosis. Then for post-treatment patients, attachment loss and bone loss are still the primary stage determinants. If a stage shifting complexity factor is eliminated by the treatment, it should not retrogress to a lower stage. So if you had furcation involvement in stage 3 or 4, and you want to treat it, would you think your patient's stage is going to regress? Absolutely not. Why we don't put it on record as a change stage? Because even if they move and switch between the dentist, right? Or if they're coming back to you, these complexity factors should always be considered even in their maintenance phase management. Does that make sense? So you don't forget about those teeth, what they were, how they were, right? So the stage will not go down from stage 3 or 4 post-treatment. Stage 2 can go back on stage 1 if the attachment loss is regenerated. That is one exception, right? Stage 2 can go back to stage 1 because there was no complexity factor, there was no teeth loss, only the attachment level was there, and 3 to 4 was there, and 1 to 2 in stage 1. So you can regenerate the attachment, the GTR, if you do the regeneration techniques. But in all the patients, do we always do the regeneration or GTR in stage 2 ones who even have 3 to 4 mm? Not all patients would go with that. Probably in the initial phase, once they have stabilized, they may just maintain that. That is why not all stage 2s will also go back to stage 1. Because if it's just maintained there, the attachment loss is not automatically naturally reversible. It is only reversible by your guided tissue regeneration. And stage 3 and 4 are not going to back in definition, Faryal. That doesn't mean they are not repairable. Stage 3 and 4 are not regressible. You can say that they are non-regressible. Understood? Like they will not go back to a lower stage. If the probing depth is 4 mm and after treatment it goes down to 2 mm, but the attachment loss will still be, no? The probing depth is reduced because the inflammation part you controlled, the shrinkage, right? The shrinkage of it got shrunk. So that's why the probing depth can reduce, but the attachment loss is not reversible unless you did a GTR for that patient. You raise the flap, put the graft, and then and you had to do the coronally placed flap for that to also cover the root if there was the recession as well, right? Due to the shrinkage. Does that make sense? That's a complex treatment. So stage 2 to go back to stage 1, you will need the coverage and the reattachment process. It was given here somewhere. All right, probably it will come further. There is a factor where we discuss this exception. But so far, everything is coming together, right? It's beautiful. Perio is wonderful once you understand it, once you know how to control, manage, and you see the facts for yourself. I think Perio is the most logical stream and discipline where you have the answers based on the facts provided to you. For example, in case of a very short common root trunk where a attachment loss of 4 mm may have resulted in a class 2 furcation, right? So this is your attachment loss of 4 mm, which is your stage 2, right? Is that correct? Attachment loss of 4 mm, stage 2. But it was a short root. So even that loss exposed the furcation and led to the class 2 furcation. The root was, so it is a complexity factor and it immediately shifts the diagnosis from stage 2 to 3. Wonderful, right? Immediately you can tell. And then further, if the bite collapsed, also mention, then you move it to stage 4. Wonderful. So patients who have been treated for periodontitis may be periodically staged to monitor them. In most of the successfully treated patients, complexity factors that have been contributed to the baseline staging will have been resolved through treatment. So all those complexity factors which you have in stage 3 and 4, as you perform treatment for them, the complexity factors will be resolved, right? In such patients, the attachment loss and the bone loss will be the primary stage determinants. Now, but if a stage shifting factor were eliminated by treatment, it should not retrogress to the lower stage because you will always consider the original stage in the maintenance phase management. So you will continue to classify that patient as that, whether stable or not, whether disease maintained or not. So we have the stabilization criteria. And is ADC asking you the stabilization criteria as well or not now? Yes, wonderful. So we are probably going to discuss in the next advanced file the stabilization criteria as well. Now, if a stage shifting complexity factor is eliminated, stage should not retrogress to the lower stage since the original stage complexity factor is always there in your maintenance phase management. A notable exception, yeah, there it is the successful periodontal regeneration that may, through improvement of tooth support, effectively improve the attachment loss and the bone loss of specific tooth. So if you did a grafting and reattachment process for a particular tooth, and even if it was the only complexity factor, then it can retrogress. That's one exception when you do the regeneration procedure. So if a stage 3 had one furcation and you did regeneration for that one, then it can retrogress. But if it has to be only one criteria. But if there are more criteria involved, which is tooth loss, that is an irreversible factor, right? Tooth loss cannot be reversed. So then the stage will not retrogress. But if it was just with one furcation, that put it in the stage 3, like all the attachment levels and everything was 4 mm or less, and tooth loss was 0, and only one furcation was the stage determining. Single tooth involved with the furcation, stage 2 or 3, right? And no other complexity factor, Shalin, no other. Imagine no tooth loss, nothing. It was just a moderate stage 2 periodontitis, but because of one tooth got furcation, it went to stage 3. But imagine it, everything else in the mouth is still stage 2, and just one tooth got furcation. So it's not as severe periodontitis per se. There is one complexity factor which would, like, so to say, documentation wise would put him to stage 3. And if you do not treat the furcation with reattachment, that will remain in stage 3. But if you only treat that furcation, the only complexity factor, and the reattachment is achieved, the bone graft is also put there. So on radiograph, you see the bone there, attachment is also formed. That's one exception. But that's a rare situation that there will be no other complexity factors and the attachment loss will be still below 4 mm, right? Does that make sense? Entirely. Because any other complexity factor, any other non-reversible complexity factor is also present and sneaked in there, then the stage 3 is not looking back. So a risk factor should therefore shift the grade score to a higher value independently of the criteria represented by the rate of progression. For example, a stage and grade definition could be characterized by moderate attachment loss, which is stage 2, and the assumption of moderate rate of progression modified by the presence of poorly controlled type 2 diabetes, a risk factor that is able to shift the grade definition to rapid progression or grade C. We're coming to grades now. So in the summary, the definition of periodontitis case based on detectable attachment loss should be at more than 2 non-adjacent teeth. That's when the periodontitis will get classified. You should be able to tell beyond the necrotizing periodontitis, systemic disease related periodontitis. And once you have established a true periodontitis, you should be able to tell the presentation, this initial, moderate, severe, or advanced, stage 1, 2, 3, and 4, respectively, and what is the aggressiveness of the disease, how aggressively it is spreading. The proposed staging and grading of periodontitis provides an individual patient assessment that classifies the patient by 2 dimensions beyond severity and extent of disease, which identify the patients as to complexity of management. So this new classification we were earlier doing when we were doing the mild, moderate, severe periodontitis, we were doing based on attachment loss, we were doing based on the bone loss. What has the new classification brought to the table? It is the complexity of managing the case and the maintenance phase, right? So once you define something, you start working on that. And the risk of the case exhibiting more progression and or responding less predictably to the standard periodontal therapy. Now let's look at the rate criteria. This is the percentage bone loss in age. Suppose the smoking and diabetes was not there. Do you think then every grade should come into the grade A? Do you think if the smoking and diabetes is absent in a non-smoker or in a non-diabetic, will always the grade be A? That's not true, right? So we easily know when a smoker is given and a diabetic patient is given, we easily see number of cigarettes, 10 or less, grade B, 10 or more than 10, then grade C. HbA1c less than 7, grade B. More than 7 or more is grade C. And in no diabetes, grade A, no smoking, grade A. But if he's a non-smoker and he is not diabetic, he can still have aggressive bone destruction and be in grade B or C. That's where you need to learn the percentage bone loss by age. So if I have a patient who has middle third, so once you've established the stage 3 or stage 4, right? That's more than 50% bone loss, 50-60% bone loss. Is that correct? And up to stage 2 is 25 to 30%, 15 to 30% for that matter. So if a patient is grade 1, stage 1 or 2, roughly let's take in between of 15 to 33, 20 to 25% bone loss, right? That would be in stage 1 or 2. And he's a young patient. He's probably 20, but he has lost 25% of his bone, and he's only 20, and he's non-smoker, and he's not diabetic. 25% bone loss divided by the age, which is 20, that is more than 1. 25 divided by 20 is more than 1. The numerator is bigger than the denominator. Simple fraction. It is greater than 1. So in young patient, even 25% of bone loss is a rapid progression of disease. Is it clear or not? But if he had only stage 1 or 2 in a 50-year-old patient, right? Does that make sense? 25% bone loss, but only stage 1, that is 15%. In a 50-year-old patient, 15 divided by 50, it's less than 0.25, right? And maybe 30% loss in a 50-year-old patient. That's between 0.5, around 0.5, 0.6. So grade B. So in the lack of smoking and diabetes, you would see the percent of bone loss by age. Does that make sense? And if you're not giving the exact percentage of bone loss, you know that stage 1 and 2 is 15 to 30, and stage 3 and 4 is more than 50. Does that make simple sense? So you don't even have to be given that percentage of the bone loss given in the history. You can get that idea from the OPG, and you have that criteria in the table. In the table, right? I'm so glad, Yatri, it's making fun. And that's the intention, is to make learning fun and easy and simplified. That's the purpose of it, right? And you will find that all our CV classes, all our special topic classes, that's how we do all the articles, because unless you make it fun, there's no fun in it, right? Grade should be used as an indicator of the rate of periodontitis progression. The primary criteria are either direct or indirect evidence of progression. When you don't have direct evidence like smoking or diabetes, then use the criteria of percentage bone loss and the age of the patient to get your bone loss prescribed from grade 1 less than 0.5 and grade 2 0.5 to 1 mm. What is this? Bone loss prescribed? I don't get, Shaleen, the doubt. You can send it to me later on WhatsApp. I don't know bone loss prescribed. I don't understand that. Okay. So clinicians should initially assume that grade B disease. If you're not provided direct evidence, you should assume first grade B and then seek the evidence, whether it's grade A or B. So if you have no criteria to define, then for the benefit of doubt, keep them in the stage B, grade B, sorry, not stage, grade B. So if you are given any history, now this is tricky and a very important takeaway point. Suppose ADC tricks you like that, doesn't give you smoking, doesn't give you diagnosis, or maybe there's no mention of his age of the patient. You can't get any of the direct evidence. 3 direct evidence we have, and we have none of the information in the exam. For example, arbitrarily speaking, nothing is arbitrary in ADC world. Everything is a variation, everything is a possible, and in one or the other parallel variation of ADC, you will see that question. So you are not able to derive any direct evidence for the grade defining factor. What should be the answer if they still ask you the grade? Stage B, grade B, Vijaya, right? It should be the grade B. And then continue to look at the evidence for A and C. Once the grade is established based on evidence of progression, it can be modified based on the presence of risk factors. So if the question does not mention the percentage bone loss in number, doesn't even give you the radiograph and asks you the grade, please put them on grade B. The gray color of the table, which is the CRP levels and biomarkers in the saliva, they are still controversial. There is still possibility that in future more evidence will be available to even link their values with the grades. For now, they are still in the gray zone, hence the grayness of the table. Okay. All right. With that, without even realization, we did it. So let's look at some of the examples that I wanted to discuss with you. Can you guys see my screen? How the radiograph might look like? How the tooth and probing depth might look like? Do you want to give it a visual? Do you want to put it into your pictographic memory? Wonderful. So do you see these beautiful x-rays which now you're going to learn and they will always remain with you as a pictographic memory and you never would make mistake. So you see it's all in the coronal third, within the coronal third, up to the coronal. That's the middle of the bone, right? That's where the middle of the root. So it's all in the coronal third. Right? So now here you see for the first situation, I'm just zooming it a bit. So bleeding on probing would be present clinically. Periodontal probing depth would be 4 mm or less in stage 1, right? Attachment loss would be only 1 to 2. It would be initial periodontitis. Bone loss is horizontal and within your coronal third of the bone only. That would be less than 15%. Plaque would be slight to heavy. That's why they have periodontitis and attachment loss, right? But there is no tooth loss due to periodontitis yet. There is moderate rate of progression if smoking is less than 10 cigarettes per day and if diabetes is less than 7% HbA1c. Does that make full sense? So this is your stage 1 and grade B. Smoking less than 10 cigarettes per day, HbA1c less than 7% is your grade B. Bone levels in only coronal third, 15% only, 1 to 2 mm attachment loss. And then probing depth is only 4 mm or less. That's your stage 1, grade B. No tooth loss would be seen in the mouth. Stage 2 would be probing depths would increase slightly. It would go 5 or more. So start from 3.5 or more in your first stage. Then 5 or more probing depth and 4 mm attachment loss is your stage 2. And no other complexity factor should be present, like there should be no tooth loss. Is that true? But look at the bone loss. It is 15 to 33%. It is still slightly above the middle third. If you divide the root into equal halves, it is very close to the half, the middle of the root, yes. Greater than your stage 1, but still not stage 3 or 4 level, middle or apical, right? And furcation is still not involved. There is still bone up till the furcation. Do you see that? Fully filled with the bone. So bleeding on probing clinically, yes. Probing depth would be 5 mm or more. Attachment loss is 3 to 4 mm. Bone loss is horizontal only. Furcation is still not involved. And 15 to 33% you would say, because it's not also the initial coronal third. It has gone deeper into the coronal third, but still not reached the middle of the root. And the stage grade would be B when the smoking and diabetes is less than 10 cigarettes and less than 7% HbA1c. So you see the attachment loss here. That's up to 3 to 4 mm. The crest of the bone is going down. That's your attachment loss. Attached gingiva starts just beneath the base of the sulcus. As the attachment reduces, the sulcus goes down. The base of the sulcus goes down. I have taught you all those core concepts. Look at the stage 3 now, how it would look on X-rays. Now you see the furcation involvement initial here, the PDL widening. Class 2 you can say, not 3, not cul-de-sac precisely, but the PDL and the furcation loss is now happening. And there is probing depth more than 6 mm. Attachment loss 5 or more is your stage 3, right? The deposits would be heavy and the furcation would have been involved, and tooth loss would be 4 or lesser than 4 in the mouth, but there would be tooth loss due to periodontitis up to 4. So there would be history of missing teeth due to periodontitis in the mouth, and furcation involvement and moderate ridge defect where the teeth have been extracted. The ridge defect would be seen on the extraction sites. Is that correct? You know where the ridge defects come. Ridge defects will happen after the extraction site, right? And don't look for them on the site with teeth, okay? And suppose the smoking was greater than 10 and diabetes was greater than 7% HbA1c, then it's grade C. And if it's less than 10 and HbA1c was less than 7%, then it would be grade B. Let's look at the stage 4. So stage 4 radiograph. Do you see middle? Middle is already crossed and it's between middle and apical third of the tooth, root portion. Do you see here? Vertical bone loss. Can you immediately identify the infrabony pockets? Right? Here, the infrabony vertical bone loss. And you see the slight drifting also of the teeth. Right? Because the adjacent tooth must have been missing in the adjacent site because there has to be 5 or more teeth missing. Do you see these are not straight teeth? And in this one, absolutely furcation involvement is seen. Right, Aarti? So probing depth would be greater than 6. Attachment loss would be greater than 5. Bone loss is more than 50% and vertical as well. And grade B and C, what are the factors, Kalyan? We just did. What are the grade determining factors? And tooth loss in the mouth should be greater than 5. Furcation involvement will be present. Ridge defect would be present. Smoking is less than 10 and less than 7 HbA1c. So this is stage 4, right? But grade B. Probing depth and attachment loss 5 and 6. Bone loss is there. You see there, grade 4. Level of bone loss, middle or apical. Up to half it's gone. It's your stage 3 and 4. So that means attachment loss is 5 mm or more. That's when your crest of the bone will go that down. Furcation involvements will be clearly seen. And if smoker had more than 10 cigarettes per day or HbA1c more or equal to 7%, then that would complex it to grade C. All right. So I hope that gave your eyes a good practice as well to look at the bone losses, apical level involved, middle third involved, furcations involved, drifts in the teeth, right? And suppose you're given an OPG, that would make the picture even more clear, right? Wonderful then. So that would be it for today's class. Want to make learning fun and don't want it to be sad, grimsy experience for you, then that's what we intend to do at Winspert. We make learning fun. The environment that we create amongst the tutor and the students, we try to achieve that positive environment while fostering friendships, fostering close relationships, and being daily for each other, for the mentorship and for the motivation that you really need for this journey. So I'll assure you that you'll not miss a friend while you're on this journey. You can message me, Juveria. I'll send you the details of the course as well, and the prices and the offer that is going on. My WhatsApp number was shared above on chat by my team, so you can check the chat and get my WhatsApp number as well. Or under this video as well, when I put it on my page, you will my team can put my WhatsApp number there also. So there is a lot of CV classes, clinical vignette classes, where we have done the clinical cases and we have done the special topics and the articles. So with that one article, you learn 10 to 20 questions immediately. Like you saw today, every time I take an article discussion class, I'm sure if you're attending that, you see that pattern, right? How one article empowers you for so many clusters and so many questions all in one. That's the strength and power behind these, these capsule classes. So I'll continue to bring more of those, and I'll see you guys. Have a fabulous weekend. Thank you for being the wonderful audience that you always are. Yes, there is actually the discount going on the full course as well. So please message me, Saad, the full course, if you want to join from now till the end of September. The full course is also running on discounted prices because we know that you have missed. But please make sure and know that even if you join my full course now, you will not miss a day of discussion. From the day one till now, all the advanced file classes, all the classes that I have taken are part of the program that would be provided. Even if you missed any mocks, public mocks, they are still there in the course. Even if you missed any mock discussion class, that's still there in the full course. Need cluster system of ADC? Yes, Anushka, I'm doing the cluster system. I've done on information gathering, I've done on treatment planning, and I've done on diagnosis and management. 3 clusters I've already taken, right? Is anyone here who's been doing all my cluster classes regularly? Okay, diagnosis is also left, Ria. So let's do those 2 also, right? Before exam, probably in the month of July only, let's do that, right? Yeah, that's a great suggestion, actually. Oh my God, I never realized you guys loved that so much, but I'm glad that they were helpful and you guys crave more of it, because that shows that you are paying attention to all the soft skills needed as well. So yeah, let's do that. Let's do both the clusters which are remaining and some other important articles as well. And message me on WhatsApp if you need any more details or any assistance. Thank you so much.